I'll be talking about cataract with macular problems, what to do when to treat when we have an choroidal neovascular membrane. Age-related macular degeneration. Old age, there are two trends. One is reading books and second is watching TV. In age-related macular degeneration, because many activities of daily living require central visual acuity, AMD decreases all aspects of patient quality of life, including the patient's ability to drive independently. And this leads to depression in elderly. So I'll be answering these four questions. Does cataract surgery worsen CNPF? When should you do a cataract surgery if you have an associated choroidal neovascular membrane? How does it help the patient in age-related macular degeneration? And what is the preferred maneuver? So first question comes, does cataract surgery worsens choroidal neovascular membrane? The answer is big no. There are multiple studies, and one of the largest studies is AIOC2023 studies, which spans over a period of 10 years. And in that 10 years, many patients underwent cataract surgery, and there was a mean improvement of +4 to +11 logMAR letters occurred after cataract surgery in AIOC1 and AIOC2 study. The participants who had cataract surgery showed no increase in risk of AMD progression versus those who did not have cataract CNPF. Another two landmarks in the studies, Marina and Anchor trial, they showed that after cataract surgery in their study patient, there was an improvement of 10 logMAR letter, meaning thereby, and there was no worsening of the vision from the pre-op vision, meaning thereby cataract surgery does not worsen choroidal neovascular membrane, in contrast with diabetic macular edema. Now the second question comes, when should you do a cataract surgery? Surgeon should decide whether the cataract is hampering central vision if you have a central posterior subcapsular cataract or a nucleus sclerosis, then you should go ahead and operate this patient because it improves the contrast sensitivity in this patient. Screening of the macular disease with an ocular coherence tomography is a must in all age-related macular degeneration patients. And there is a study where where they compared the slit lamp biomicroscopy result with an OCT result, and the evaluator was a vitreoretinal surgeon. The overall management of 26% out of 411 patients was modified on OCT findings, which were either missed or underestimated by fundus biomicroscopy. So again, what the previous speaker and what the members on the dais were speaking, that you should, if you are suspecting age-related macular degeneration, and you should go ahead and do an ocular coherence tomography to diagnose this disease. The third question comes, when should you do a cataract surgery? If cataract with CNBM is diagnosed at presentation, first treat the CNBM with 3 loading doses. Once the lesion becomes dry, then go ahead and do a cataract surgery. Cataract surgery is avoided within 6 months of starting the treatment for neovascular age-related macular degeneration. If lesion does not dry up, then you can go ahead with a simultaneous cataract surgery with an anti-VEGF can be planned simultaneously, and this is a small video where we have done cataract surgery and given intravitreal injection in this patient, and a direct chop is done. And once the cortical aspiration is done, after putting the lens and before aspirating the viscoelastic, we go ahead and inject the anti-VEGF. That is 3.5 millimeters behind the fingers. Once the anti-VEGF is injected, then only you go ahead and do the visco wash. How does it help the patient in age-related macular degeneration? It increases the contrast sensitivity, thus helps in near vision. It also improves the BCVA and peripheral vision, thereby helping in daily activities, decreases the glare and improves the color vision, and thus helps with the quality of life indices. There is a study where if you do a cataract surgery in a patient with age-related macular degeneration, the incidence of fall decreased by 54% once you do one eye. And if you do both the eyes, then the incidence of fall decreases by 73%. So actually it helps the patient in its daily activity when we think that patient is blind and nothing can be done. Improved binocular visual acuity and contrast sensitivity were associated with decreased number of falls. So, which is a preferred IOL? The question what the last we were answering. Unifocal aspheric IOLs are the best in cases of age-related macular degeneration. Toric IOLs do not compromise contrast sensitivity and can be used in patients with age-related macular degeneration. Multifocal IOLs should be avoided. That was the message 5 minutes before, and that's a message now, that don't use multifocal IOLs because it decreases the contrast and has a higher order aberrations. Evidence that EDOF IOLs are well tolerated in patients with age-related macular degeneration would be required before advocating them. To conclude, cataract surgery does not worsen age-related macular degeneration. OCT scanning is a must before taking the patient for surgery. Cataract surgery should be done after 6 months of initiating the treatment. Simultaneously, cataract surgery with anti-VEGF can be considered. There is an improvement in BCVA and contrast sensitivity, which improves the quality of life, and multifocal IOLs should be avoided. Thank you very much for your attention.
Thank you very much, Dr. I think the message is very clear on multiple aspects. One is that ARMD doesn't progress after cataract surgery. In fact, we looked at our data of more than 50,000 patients of ARMD, and what we found that actually after cataract surgery, the ARMD prevalence was showing to be higher. But when we looked at it very carefully, what was happening was, once the cataract surgery is done, within 1 to 3 months, when the vision is not improving, look carefully at the fundus and then start analyzing the reason why the vision is not improving. And also the fundus view is better. But if at all we expect increase in ARMD after cataract surgery, it should not be within 1 month to 3 months. It should be a long-term effect. But the entire increase was happening within 1 to 3 months. And that gives, obviously the ARMD is not increased by the cataract surgery by itself. The other thing is the multifocal IOLs. Please do not, there is no effect on the patient's quality of life. In fact, it could worsen the quality of life of the patient as well as the treating retina doctor both will suffer.
Yes, see, my take on this would be always treat CNVM first. Because in such, unless cataract is, obscuring the view, otherwise, I would go ahead and treat CNVM when the time macular dries. Because if the cataract is dense enough, in any case, your evaluation is not possible. I've seen it. Then you can, unless patient is following up with you and cataract becomes dense, and you have to give your, treat and extend next injection, then you do a combined kind of procedure. If cataract is not dense, you can evaluate very well. Always treat CNVM first. There is no doubt in that matter. I think whatever vision he has told, there is not even an iota of difference amongst the retina colleagues, whatever he has said. Yes. Comment or any?
Talking about preoperatively you see bruising, but it always means
that is unrelated to the cataract surgery. So preoperatively, if you see bruises, that is one of the definitions of macular disease. If you look at the AREDS classification, they should be, we are not talking about less than 65 microns. So the interrelated bruise more than 3, they come under the classification.
whether they have had a sign for the AREDS just seeing the bruising, a large bruising.
Large,
it is an AMP or not.
just drusen does not qualify into age-related macular degeneration. The definition is if you have a confluent drusen with a simultaneous decrease in vision of less than 6/9, then you define this patient as age-related macular degeneration.